morning, everyone. This is Al Cardillo. I'm the president of the Home Care Association of New York State, and I'm here with Eve Banker, my colleague from IPRO, and together we will be presenting this webinar to you on home care sepsis screening and intervention. Eve is the Senior Director for Quality at IPRO and the Director of the sepsis special project that was done in New York in conjunction with CMS. As you know, HCA has been heading up this really nationally unique program in sepsis intervention and screening through home care. Today's webinar is being recorded. Questions can be posed in the participant feedback box, the check box, and we encourage your questions throughout. We'll probably stop at certain key points to address the questions. But we will be, moving through this presentation today, initially with background on sepsis, then going into detail on the sepsis tool, and talking about how to apply this to within your agencies, how to adopt and implement this key tool. Today's webinar was exclusively for agencies that have either not had an opportunity to attend and participate in the training that IPRO and HCA have done to date around the state, or if you really felt that you needed a further introduction to this to consider your use of the tool. We really encourage all home care agencies in the state to consider adopting this tool and making it as part of your standard practice. I will say that there continues the interest from around the country to implement the tool in other states by other types of healthcare providers, and that is something that we've also been working on steadily as we go through. So let me continue the presentation. Okay, first I think it's very appropriate to start with a dedication of the purpose. And truly, in New York State and across the country, many lives have been fundamentally lost or affected by sepsis. And it's really those individuals and what we know is happening literally on a daily basis, an hourly basis, and by the minute in this country as it relates to sepsis impact. That is really what inspires what we do. The individuals and the surviving families have given great testimony and inspiration to why this is such an important initiative, and as Eve and I present, I think that will become clear in terms of the challenges that are faced both on the front end in terms of identifying and responding to sepsis, and then on the far end for those who survive sepsis, for the interdisciplinary treatment and intensive care that's really required as they try to resume their lives. So today we're going to be talking about the sepsis tool, and there'll be other slides that go into much more detail, but I just wanted you to see up front what the tool looks like. You'll see on this slide the tool is in the middle, the screening tool. To the left, to your left, is an algorithm which will just help guide clinical decision making, and to the far right is a patient education tool, and they really all work together to implement this initiative. There is one more piece of this, which is a protocol, and we'll review that with you later when we're more in depth on the tool itself. We branded this initiative Stop Sepsis at Home New York, and we've been working throughout with core partners. So the core entities in this effort have been the Home Care Association, IPRO, Sepsis Alliance, and the Rory Foundation for Sepsis Prevention. Our clinical process has been led by Amy Bowerman, who is at the Mohawk Valley Health System. She's the Director of Senior Network Health. She's also the Quality Director for the VNA of Utica. And we brought Amy into this process because she was the leader in implementing a sepsis tool or sepsis protocols really across the continuum at the Mohawk Valley Health System. So we really had an excellent leader throughout the way in the development of this tool. We have been supported over the last year by a grant from the New York State Health Foundation. They were very excited and supportive of learning what this effort was all about, and the grant has supported the training that we've done around the state, including today's webinar, which has been made available to everyone. The Health Foundation awarded this grant to HCA to work with the core partners that I just described to conduct statewide training for the assistance in statewide adoption of the tool by all home care agencies in New York State and also by any other clinical entity where this tool would be appropriate for sepsis identification and intervention. So we're now going to just air for you a short video, which will be an introduction to sepsis and what it is, but also so that you can. It's a reflection of the support that is being provided for the initiative. The video is the State Office for Aging Commissioner Greg Olson and myself, and also then an embedded video of Sepsis Alliance really putting a face on this issue, but thought this would be a very good table setter for the next part of our presentation.
Have you heard of the term sepsis? If you're like many Americans, you might have heard it, but really aren't sure what it is. I can tell you, you're not alone.
Sepsis is the body's overwhelming and life-threatening response to an infection. It can lead to tissue damage, organ failure, and death. In fact, over 270,000 Americans die of sepsis each year.
Hi, my name is Greg Olson, and I'm the director of the New York State Office for the Aging. Sepsis can and does impact people of all ages. However, it disproportionately affects older adults. In fact, more than 60% of sepsis cases are for individuals aged 65 and older, and the majority of those are found in the home and community, not in a hospital.
And I'm Al Cardillo, president of the Home Care Association of New York State and a member of the National Sepsis Alliance Advisory Board. Know the signs and symptoms of sepsis: shivering cold or temperature, extreme pain, like I feel like I might die, pale or discolored skin, shortness of breath, and confusion, difficult to arise, not really able to think clearly or properly. These are some of the critical signs and symptoms of sepsis, which if you detect, or if a family member detects, it's important to call your provider right away.
The following stories really illustrate the devastating impact that sepsis can have on families. Why don't you take a look?
My mother, a 20-year breast cancer survivor, she dies of a disease that we never even heard of.
Septic shock, sepsis, and she was like, how do you spell it? I was like, I don't know.
Really, does it affect that many people? Then why haven't I heard of it?
My mother, Mama, she had plans of being a gospel singer. They found a clot in her femoral artery. She got through that surgery, but she started complaining of a lot of weakness, couldn't catch her breath. When I heard the word sepsis, I didn't understand it.
I remember that I went to bed, woke up to find the EMTs in my room. My doctor friend called the hospital and said, look, unless somebody's coding, there's no one in there as sick as this man is right now. Get a doctor in there. In the next few hours, I had one shutdown after another, all of my organs, lungs, kidneys, eventually a heart attack. My toes were blackened and gangrenous. It was very unclear as to whether I would survive.
It was Halloween. He was up crying. I took his temperature, 102.3, and his color was gray. His lips, his everything was gray, and he was not responding. We got to the hospital. He got swelled up. So he was huge. And one of the doctors said, we don't know if you'll be able to take him home. I'd been waiting for him for all these months, and I've only had him 3 weeks. He's mine. I wish I would have asked more, but I felt like I was supposed to know as a mother.
I didn't understand that any infection could result in a toxic response that is known as sepsis. It started when I went to the dentist and had some dental work. Following that, I developed an infection. And then septic shock.
I can't even describe to you the horror of seeing her die of sepsis. The body swelling up twice its size, fingers turning black, having to be intubated. It looked like someone took a shotgun and shot her in the leg. That's what it looked like.
For me, this could have a very different ending. And it's why I share my survivor story.
And the nurse, her name was Annie, and she says, "Are you ready to hold him?" And I said, "Oh my God, yes." She put him in my arms. And she says, "He's gonna be okay." I thought maybe if I share my story, somebody will learn from it.
Mama's gone, but maybe somebody else can be saved.
I want to thank you for watching, and remember, sepsis is a serious medical emergency that requires immediate action.
For more information about sepsis, go to some of the key resources on sepsis. Rory Staunton Foundation for Sepsis.org, Sepsis.org, and Stop Sepsis at Home NY.org. Thank you.
So I would like to thank very much the State Office for Aging and Sepsis Alliance for their collaboration on that public service announcement. That has not been officially released yet, but that will be released across the entire state of New York by the State Office for Aging shortly, and you really have had the first introduction to it. But our hope is certainly that that will help in promoting an understanding about sepsis, and the particular interest of the State Office for Aging is that sepsis is really especially prevalent in the elderly, and it's just an important messaging effort by them. So I'm now going to turn the program over to Eve Bankert to discuss critical facts about sepsis and sepsis background.
Good morning, everyone. So the next few slides are really going to be discussing just overall basic facts and key messaging about sepsis. Some of the information is going to be redundant of what was mentioned in the video and by Alan Gregg, but we all think it really bears repeating. So sepsis is the body's systemic, or meaning whole body response to an infection that can cause damage to healthy tissues and organs. And if it's not treated appropriately and promptly, sepsis can result in death. To give you a big, more global understanding, sepsis is really a worldwide problem, and it's the leading cause of death and healthcare spending globally. Here's some sobering statistics about sepsis. The mortality rate for sepsis is greater than that of heart attack, stroke, and trauma. Every 2 minutes, someone in the United States dies from sepsis, and every 20 seconds, someone in the United States is hospitalized with sepsis. It's the most expensive condition that's treated in United States hospitals, and as Al mentioned, it kills more than 270,000 Americans annually. 7 out of 10 sepsis patients recently had an interaction with a healthcare provider. So this illustrates the great opportunity that we have as clinicians and as healthcare professionals to identify sepsis earlier for better outcomes. So in all cases, a diagnosis of sepsis needs to be treated as a medical emergency. The reason for this is that sepsis can progress very quickly to severe sepsis and septic shock. So catching it in the early stages really leads to better clinical outcomes. So as with any initiative, collaboration amongst partners is one of the keys to success. With sepsis, having a unified call to action, aligning goals, and involving partners across the care continuum ensures a cohesive response. The alignment of pre-hospital, in-hospital, and post-hospital care settings is imperative for the best clinical outcomes. It's also important to analyze and utilize data as a driver of improvement and change. So sepsis is one of the most under-recognized and misunderstood conditions by healthcare providers and also the public. And there are many misconceptions about sepsis, one of which is the belief that sepsis is something that you catch in the hospital. Sepsis is something that is developed, and greater than 80% of all sepsis cases originate in the home and community and not in the hospital. Also, there's a great misconception that sepsis is synonymous with MRSA. This is not true. MRSA is just one of the many bacterial causes of sepsis, but it is not synonymous with sepsis. Number 3, sepsis is a rare condition. This is also not true, as you'll see in the next slides. Sepsis only affects the elderly and the frail. No, sepsis is an equal opportunity infection or condition, and it can affect anybody at any age or any ethnicity or sex. Sepsis is easy for healthcare professionals to diagnose. This is true, unfortunately, in the late stages. It is easy to diagnose, but in the early cases, it can sometimes be missed. Once a person recovers from sepsis, there are no long-lasting effects. This is also not true. There is something called post-sepsis syndrome, which affects up to 50% of all sepsis survivors. And lastly, sepsis rarely occurs in the outpatient setting. This is false. So sepsis is an equal opportunity killer. It can affect the ill, the healthy, the young, and the old. There are, however, people who are at higher risk for developing sepsis: older adults, babies under the age of 1 year, those who are chronically ill or have immunocompromising conditions, people recovering from surgery or have been recently hospitalized, and those who have had sepsis in the past. All of these high-risk people are at increased risk for infections and potentially developing sepsis. So one of the important things that sets sepsis apart from other conditions is its association with infection. Sepsis is always triggered by an infection. Sometimes people don't even know they have an infection, and sometimes the causative agent of the infection is not identified. But if symptoms of sepsis exist, a source of the infection should be sought by the healthcare provider. These are some of the early signs and symptoms of sepsis and severe infection. Look for a combination of symptoms: clammy or sweaty skin, fever or shivering or feeling very cold, confusion, rapid heart rate, shortness of breath, or extreme pain or discomfort. Other early signs may include a decrease in your blood pressure, an altered mental status, or a decrease in urine output, or dark, concentrated urine. You may also have some abnormal lab tests. Unfortunately, there is no gold standard diagnostic test that exists to diagnose sepsis. These are some of the most common infectious diseases that may progress to sepsis. pneumonia, skin infections or cellulitis, urinary tract infections. These are the top three, but also influenza, endometritis, and C. difficile enteritis also can develop into sepsis. The treatment for sepsis is usually conducted in a hospital with a prompt administration of intravenous antibiotics and fluid administration. So sepsis treated in the early stages results in much better outcomes and reduced risk for long-term complications. The time to treatment is critical. The mortality rate for sepsis increases by 8% for every hour that appropriate treatment is delayed. And if not treated promptly, sepsis can progress and lead to organ failure, tissue damage, or ultimately death. Antibiotic stewardship and treating sepsis are not conflicting strategies. Urgent antibiotic therapy is needed for bacterial infections to prevent progression to sepsis and septic shock. So why community-based? Greater than 80% of the cases originate in the community and not in the hospital. Also, sepsis mortality is largely preventable if we identify it early. And it's been shown by national studies that only 58% of U.S. adults have ever even heard of the word sepsis. And as we mentioned earlier, the early diagnosis may be missed by healthcare providers. Sepsis is also the #1 reason for 30-day hospital readmissions in New York State. And in New York State, sepsis treatment protocols and education has been focused primarily on the emergency departments and the critical care units. So the IPRO initiative has conducted a lot of sepsis training in home health agencies, skilled nursing facilities, physician practices, dialysis centers, and also school nurses, and most recently substance abuse treatment centers. To date, we've trained close to 10,400 pre-hospital providers and caregivers on sepsis awareness. These are some of the care coordination tools that we use in our training. I'm not going to go over these because Al is going to be talking in depth about the HCA Adult Sepsis Screening Tool and Protocol, and also the Sepsis Zone Tool. But I just want to make you aware that there are also specific tools for skilled nursing facilities and physician practices. So this is, Al showed this to you earlier. He's going to go over this in depth. This is the screening tool that we're going to be discussing. And this is the zone tool that is part of the screening. We also have sepsis brochures that are written for the general public. It really just includes most of the key messaging that is associated with sepsis education for the community. And this is another sepsis brochure that really illustrates the importance and the value of antibiotics in the early treatment and management of sepsis. So New York State is one of 3 states that has that has regulations that requires all hospitals to have policies and protocols in place for the early recognition and management of sepsis. These came about due to Rory's regulations, which were enacted in 2013. Patients that are hospitalized for sepsis are more severely ill than those hospitalized for other conditions, and they have longer lengths of stay, and they're also more likely to die during their hospitalization as compared to those that are hospitalized for other conditions. The post-sepsis syndrome, as we mentioned earlier, can affect up to 50% of sepsis survivors, and this can lead to things such as amputations, impaired cognitive function, mobility impairments, loss of self-esteem, and these things can be with patients for life. So the preventative measures essentially are preventing and treating infections promptly. consistent good hand hygiene, staying up to date with all vaccinations, and just maintaining good overall health.
Thank you, Eve. So now I will talk about some facts that help further show the relevance of sepsis to home care. One of the things that we found when initially looking into the area was basically the question, what does this have to do with home care? Isn't this a hospital problem? So some of these statistics are things that Eve had pointed out, but sepsis is inherently an imperative in home and community care. 80 to 90% of sepsis infections occur in home and community. 1 in 4 are readmitted to hospitals. It's the number one cause of readmissions, the number one cause in avoidable Medicaid hospitalizations. There's a hospital admission every 20 seconds, and it's the number one cost of hospitalizations in the country. The highest risk populations are in home care or within the typical reach of home care and primary and community partners. As Eve emphasized, early recognition and time to treatment is critical. It's important then to maximize prevention and awareness and pre-hospital and community intervention and partner synchronization. And we'll talk more about that collaborative component as we go forward. But also post-sepsis transition and care are critical, with recurrence and readmission risk very high, and a need for complex interdisciplinary follow-up care. Also, he referred to post-sepsis syndrome, which really creates a complex set of needs in the patient population upon discharge. These cases are really primed for collaborative follow-up by hospitals, home care, and other partners. So among the highest risk populations, again, are the elderly, the chronically ill, persons with disabilities, the very young, especially medically fragile children, individuals with compromised immune systems, individuals with recurrent UTI and pneumonia, and others that are routinely within home care scope and reach, post-surgical, maternal, and neonatal care. These high-risk groups are the home care population, and for all the home care providers participating in the webinar, I think that when you see these characteristics, I'm sure that you see in them your own populations that you serve. So home care treats the populations that are really most vulnerable to sepsis. Home care also has a unique credentials to position it as an effective sepsis partner. And these include the fact that home care clinicians are in homes and communities where sepsis is most prevalent. Home care clinicians are also expert educators, screeners, evaluators, interveners, and system navigators. And when you consider the time element and the partners that need to coordinate when there's an identification of sepsis symptoms, you recognize then the importance of the clinical competency of home care nurses and clinicians in being an intervener in that effort and a navigator in that effort. Home care is also a patient and culturally centered and cost-effective vehicle. So certainly, as we look for different partners and different care settings to have a role in intervention, home care is a cost-effective program within the overall continuum of care. Also, sepsis is one of those conditions that's typically associated with healthcare disparities. So there are individuals in communities, minority communities, other communities that are especially susceptible to latter stage diagnosis, latter stage intervention, and the cultural centeredness of matching the home care clinical staff, the home health aide, with the patient is really a key ingredient in fostering the education and the prevention and the intervention in a timely way that allows for a more effective response. And of course, home care is also the growing and future milieu of care. So when we consider the fact that, for example, under DSRIP, a goal of moving 25% of utilization from the acute care sector and emergency room sector into the community sector over this past 5-year period, culminated in 2020, certainly suggests an important shift of the population into the community. We also know that virtually every federal and state policy is really oriented toward trying to reinforce the right care in the right place at the right time, and all of that really means much more care in the community. So it only makes sense with the number one healthcare condition like this, that home care is ramped up and is a fully participating and leading partner in this effort. These fact patterns really point to the importance of increasing sepsis early identification, early treatment and mitigation, and community health education. Points to the importance of patients' primary and community providers like home care keying in on sepsis risk, sepsis education, screening, and immediate and emergent follow-up upon signs and symptoms. The importance of standardization of sepsis criteria and protocol in home care, and particularly across settings, and protocols that sync with physician, EMS, hospital, and other partners. So Eve spoke earlier about the protocols that are in place in hospitals. These protocols and the criteria that drive these protocols are the same ones that we have utilized in the creation of the sepsis tool and this intervention initiative, which we will be going through in more detail with you. So what's very important in that arrangement is that for all home care agencies to have a standard process that matches what the hospitals used, and in fact that matches what is substantially used in EMS, ensures coordination of the communication patterns and synchronization of assessment, diagnosis, and then certainly entry into a prompt and rigorous care for the patient population. In our work with the State Hospital Association, one of the emphasis that they have made with hospitals across the state is that this particular home care tool is something that establishes a standard, so that hospital emergency room personnel, other clinical personnel can have confidence in that the referrals that they receive from home care agencies are on the same base of assessment criteria as they would use. And this is, again, certainly the messaging that we are also rolling out to the medical community and to other partners in this process. So again, I really emphasize the point of using a tool like this in your own work in sepsis, because it really advances your position in dealing with partners and ensuring prompt care for patients. And of course, the collaboration effort is very, very critical, again, for pre-hospital as well as post-hospital care. So now I'm going to speak in some detail about the sepsis tool. First, presenting you with a little background on how we developed the tool. I think that's very important so that you understand the depth of the effort that led to this and the foundation of partners that we have, both statewide and nationally, in the development of this tool. And then I will walk you through a detailed description of the tool and how it applies in cases. So starting about 4 or 5 years ago, we undertook an effort to determine whether and how home care could collaborate in the prevention and intervention effort for sepsis. And this really came to our attention when we received outreach from the Sepsis Alliance that was really polling all the sectors in different states. Have you ever heard about sepsis, and what are you doing about it? So when I received that call and engaged in the conversation, one of my first steps was to reach out to clinicians in home care across the state to see what the experience was within home care agencies of addressing sepsis in the home care setting. Most of what I got back was, well, this is substantially a hospital problem, isn't it? Also, that while this was a very serious illness and something that really needed a great deal of attention, that it wasn't largely being seen in home care. So that was the level of feedback that I received, and so we sort of put that on the radar for continued follow-up, but really the overall impression as to its urgency and prevalence in the community wasn't manifest in that feedback. Later, in our work with IPRO especially, and members of our quality committee, looking into metrics for quality care, in particular managed care, we detected that sepsis and tracking of admissions and readmissions for sepsis was something that was a discernible metric within the healthcare system. So what we felt was, well, if it's a metric, if admissions and readmissions are a metric, then it must be that the prevalence in community has to be pretty substantial. So as we initiated our research and came across the data of 80 to 90% in community, it started, and the amount of readmissions, it really started to validate the fact that we really needed to pursue this as a contributor to a public health response in the state. So we researched across the country, and we communicated with the top researchers in sepsis and some of the top facilities that were doing cutting-edge work in sepsis identification and mortality reduction. Not one of them had a community-based or a home care-based part of their model or in the scope of their research. At the time, really the most that we were told was that, you know, that sepsis was being looked at on the critical care side, and the newest developments were to look at sepsis and sepsis response in the ER, but not really a pre-hospital, though it was certainly recognized that early identification was important. We then engaged experts from both state and national levels, and you see the names on the slides. We certainly could not say enough about these individuals and their contribution to our effort. We had Dr. Martin Dorfler from the Northwell system address our quality symposium, and in that he talked about sepsis and the etiology of it, and really focused on the importance of early detection, pre-hospital detection, if at all possible.
Do you want to be on the next slide?
Excuse me?
Oh, should be. You're saying it should be on the next slide.
I'm thinking, no?
I'm sorry,
No,
is there?
Yeah.
Okay.
Are you supposed to be on the next slide?
No.
No, okay.
Okay.
Sorry.
So I'm sorry about the interruption. So in that presentation, that really cued to a focus by HCA on home and community-based on looking at the home and community-based component of sepsis, and Dr. Dorfler really reinforced that and certainly offered to assist us further in that effort. So in that context, then we followed up and we created a work group related to sepsis to sort of study how might we be able to contribute. What should be home care's response to this effort? We also tapped for that Dr. Stephen Simpson, who was the Chief Medical Officer of Sepsis Alliance. And in his effort and in his conversation really reinforced the messaging from Dr. Dorfler and encouraged us to go forward. So we convened for this work group Amy Bowerman, who chaired this effort, and Amy really led the drafting of the tool, the corresponding algorithm, and the protocol. So you see in this picture here the tool and the algorithm, and I'll show you the protocol shortly. This was a multi-year process in developing the tool. Our own Jenny Kerbin, who's our graphics director, designed the appearance of the tool and that layout. The tool was vetted, it was beta tested several times, and with the input of the beta test, the tool was again further refined and then ultimately finalized in that effort. So the tool and the initiative that evolved are the first of its kind nationally, and to date this is the only statewide home care system tool for sepsis in the country, and it is being widely supported in both our state and by national organizations and concerns. The comprising instruments, as I pointed out, include a sepsis screen, an algorithm for clinical follow-up to the screen, the protocol for standard use of the screen, and the patient education tool. So the sepsis tool, as I mentioned earlier, was specifically designed to sync with the hospital criteria and Rory's regulations. And we've mentioned Rory several times, and I just want to be sure that everyone knows the Rory Staunton story. So just pause for just this moment. Rory Staunton was a 12-year-old boy in the New York City area that suffered really what was a minor cut playing basketball in gym. The cut resulted in an infection, and Rory started to feel ill. And despite repeat engagement with the medical care system, the fact that Rory was ill from the infection and ultimately from sepsis was really missed in the process. Rory died tragically several days later. Rory's parents, Karen and Orla Staunton, who have been very close partners with us in this initiative, established a foundation in Rory's, in tribute to Rory's life, to ensure that no child should die because sepsis was undetected, and really beyond that, no individual, young or old, should lose their life because their symptoms and the criteria was not recognized. So the loss of Rory led New York State to work with the Stauntons in creating Rory's regulations, which, as Eva pointed out, have now been adopted in several other states. So the tool is specifically designed for use by home care clinicians, but it is also applicable to and being sought for use in other settings, including joint models with hospitals and ambulatory care and in other partners, and even nursing homes have been looking to adopt the tool. So we strongly believe that the collaboration of continuum partners is very, very critical in achieving what we believe needs to be a continuum response to sepsis. Our goal, as I mentioned earlier, is statewide adoption and integration of the tool and the companion instruments by all home care agencies and in other applicable settings. The orientation and training on the tool and on sepsis substantively are prerequisites for provider use of the tool. So here I want to just be sure to emphasize that in our process for rolling out the tool, we really require that providers be trained and oriented in its use. And this webinar is an important first step for all of you in that process. What we also ask of you is that you participate in the training the further training that's webinar based, that will really further reinforce what we're presenting to you today, both baseline information on sepsis and the use of the tool, the adoption of the tool and integration of the tool. There's a progressive series of webinars that are accessible at that link that you see in the slides, and we will make sure everybody who's on this call has access to the slides. We'll either send them or we'll post them to our website so that you have them all available to you. So that's something very important, because the tool has to really be used consistently and accurately as a clinical document, which you would then adopt into your own clinical practices and protocols. So we don't just post the tool and make it available for the use of agencies as they might put it in place. It really needs to follow the protocol, and it needs to be adhered to in terms of the way it's filled out. And the way in which we control for that basically is that we have a user agreement that any agency in New York or out of New York can complete, and that agreement basically just covers what I'm describing to you now. The other element is that we ask any agencies that are using the tool to really use it the same way and not alter the tool, and also not distribute it to those that have not gone through the same type of preparation. We think this is very important for quality and quality assurance in this process. So the tool was formally launched at the end of March 2017. We provided a written notice to the State Commissioner of Health and to the department, so that both the department centrally and all the surveyors would know that this tool is in place. And I think what's important to appreciate is that this tool in the home care sector in New York is being done as a voluntary initiative, a proactive initiative on the part of the home care community. Eve mentioned earlier that the Rory's regulations were created through the implementation of a regulatory protocol, and in other states by legislation and regulation. One of the things that distinguishes this is that this has been done from a more or less a customized basis from the grassroots up. So the tool was, again, developed and tested and designed for use in the home care setting. On the hospital side, the hospitals were more or less mandated to put a protocol in place, but the details were left up to each hospital to establish. So in this case, we've not only developed the tool, but as you will see as we go forward, there's other training resources and information that will guide every agency in putting this in place within your practices. So New York providers have been using the tool, been reporting extremely positive experience in their use, and additional agencies are adopting this on an ongoing basis. And as I mentioned, providers and organizations in other states are seeking to adopt the tool and have adopted the tool. I talked about the grant that we were awarded, which has also helped this process. But I think this next point and slide will really show a great testament to the home care field. So when we rolled this out in March of 2017, if you looked at a map of New York State, there might be a few dots that would represent those providers that had worked with us to beta test the tool. But largely, a map of New York would be substantially white. If as of June 1, 55 of the 62 counties in our state have at least one home care agency that has trained and been authorized for the sepsis tool. And I would like to show you what our state looks like now. So that's what our state looks like now on the basis of home care agencies going forward on a proactive way and adopting this tool, in effect self-mandating the tool as part of their practice rather than kind of wait for the state to mandate that on the systems. As president of this association, I'm very proud of what our industry has done, what our professionals in our sector has done to basically paint New York almost entirely yellow in a year and a half. And I would dare say if it was a state mandate, we might have the reverse in terms of what you would see, because that's the kind of time and effort that really it takes. And that's also certainly a testament to the partners, to IPRO, Sepsis Alliance, the Staunton Foundation, for all of the effort over the last year and a half. We know that providers in those white counties that you see have also expressed interest. We just don't have the information in terms of whether they are actively putting the system in place yet to be able to make the entire map yellow. But I think that is an important testament, and I hope for all of you on the phone as you're considering on the webinar, as you're considering the use of the tool, to see what robust response your colleagues have given to date. I think we skipped a slide. So thus far, agencies that are using the tool are reporting success with early sepsis identification and treatment at home, and in some cases, in conjunction with a physician, avoiding hospitalization. One home care agency has reported at this point, well over 100 cases that have met sepsis criteria that they have treated in the home with a collaborating primary care physician. If you just look at those cases alone and you consider the average cost of sepsis treatment in hospitals, that's savings in the millions of dollars. That well positions an agency in a value-based equation or as a valued partner to hospitals, physicians, managed care plans. It positions home care agencies that are using this tool in a very, very positive way in intervening on this, what is the #1 hospital expense. The agency also reported the identification of severe sepsis and timely intervention in those cases, largely via transport to the ER. So in those cases, the positive outcome is they're making it to the ER while they're in a position where sepsis can still has a better chance of being effectively treated, reducing morbidity and mortality. And over 200 cases have been identified in meeting criteria for severe sepsis and delivered timely to the ED/ER. Also, one thing that has been a reported result since even the beta test period of this tool has been broader awareness in terms of screening and prevention of infection overall. And we know that that's very, very critical in terms of its own role in morbidity, mortality, hospitalizations, etc. I think related has been the increased participation of home health aides in their own awareness of some of these key triggers and potential criteria of sepsis that have increased report from home health aides to clinicians at the home care agency, alerting them as to potential symptoms of sepsis. But even when they're not manifestations of sepsis, they're manifestations of other high-risk criteria that really demand a timely treatment. So it has really been reported beneficial all around. Along with this tool has been the development of a data portal by IPRO. All users of the tool are really asked to register into this portal. That allows you to upload the data of all of your screens into this process that will then give you feedback on exactly what your patient population looks like, how it looks in terms of the critical criteria, which are indicators of sepsis, and it also provides you with good population health data on your patients. We then can also access de-identified information, and we will have a unique set of information in the country on what the sepsis profile is like in the community, which also affords us opportunity to work with key partners like hospitals, EMS, and others. We created a Stop Sepsis at Home website. That's the website there and the link to it, and we encourage you to visit that website as you go forward in this initiative. I wanted you to see the collaborating partners that we have as part of our steering committee that we convened to this effort. Every major association in New York State, whether they are a hospital side, a consumer side, health plan side, EMS, and others, state agencies have been involved in this effort. So this has been a great opportunity to also just work to integrate the work of home care with all of the other sectors, and I believe it really elevated home care's role in being a contributor to a number one healthcare problem. Again, just so that you have them, these are slides on our core partners. We encourage you to visit both the Sepsis Alliance and the Rory Staunton Foundation for the resources that they can offer you as agencies. The resources are video, our written material, our protocols, and also for work with partners. Again, incredibly helpful resources in your own work and your staff training. So now I'm going to provide you with an in-depth review of the tool itself and a review applying to some cases. So this is a full shot of the tool and the algorithm itself. And now we'll go through each section of the tool. So the tool is really divided into three sections. The first section is further subdivided into three sets of questions, three sets of information gathering. The first really relates to the patient's history of infection or the existence of an infection or a potential source site of infection. And then there are various potential or existing source sites which are indicated there and an open box if it's actually an infection from another source. This is important in establishing whether or not the patient, by presentation, has a risk factor. As Eva said, sepsis is always correlated with an infection. It emanates from an infection and the body's response to an infection. So that's a very important piece of information to collect. The second part relates to the presence of systemic criteria. And those criteria are very critical because they in conjunction with the presence of an infection or suspected infection, are important in trying to determine whether the coexisting criteria are indicative of the onset of sepsis in that patient. The third category relates to an indication of a new onset of organ failure. And again, goes through all the various organ systems there, and the key is a new onset or an exacerbation of a organ function in any of those particular areas. So again, the first part of the tool is to examine the patient from each aspect of that medical criteria. The second part relates to follow-up based on the answers to those first three questions. So as you see in this, if the answer to question 1, is there a presence of infection, yes, and the answer to 2 and 3, the presence of systemic criteria or organ dysfunction, no, then the decision-making aspect takes you to educating the patient on signs and symptoms of sepsis, and you provide the patient with the sepsis education document that we'll get to in a moment, basically the zone tool. If the patient meets if the answers to questions 2 and 3 are yes, so if there is evidence of systemic criteria and or organ dysfunction, then the patient is educated on signs and symptoms of sepsis, and the MD is notified of the findings, and those findings are documented. If the answer to questions 1, 2, and 3, so evidence of infection or history of infection, systemic criteria, and organ dysfunction. If the questions of 1 and 2 are yes, but the answer to 3 is no, so infection and systemic criteria, if they are yes, but there is not presence of organ dysfunction, then the patient meets the criteria for sepsis. The findings are documented, the patient is educated, the provider is notified, and there is a clinical follow-up to that. If the answers to all 3 are yes, so basically if there is evidence of infection or source site, systemic criteria, and organ dysfunction, then the patient meets the criteria for severe sepsis. Those findings are documented, there's a communication with the provider, and most likely that patient is then transported through EMS or by the family to the ED for evaluation and follow-up. The third area is really a documentation of the interventions. So the interventions are really the interventions which would follow from the follow-up that I just described. It's important to really note that this is not a rigid system. This is also not a diagnostic system. It's an assessment system to ascertain the risk criteria that that patient is exhibiting and guiding the provider to engagement with the physician and or other parts of the healthcare system to follow up in that continuum. And the intervention would then be a checklist of what the exact follow-up would be, including if this is a patient with an advanced directive, let's say in hospice, with 24 or 48 hours to live, that's going to be a different intervention or could possibly be a different intervention than if it's a patient that's not in that status where intervention would be called for and necessary for that patient. This next slide is the algorithm. So this is really a pictorial representation of what we just went through verbally on the screening tool. And the algorithm, you can see in these next slides, really lays out in a very clear way what each step should be based on the responses to the questions in the screen form. So here you see the Patient Education Zone tool, which was designed and developed by Eve in her work with IPRO and the separate training that IPRO did under a CMS special projects in sepsis identification and intervention. So the tool really is to be used to help educate the patient and family, but is also used to help throughout the users of our tool to help educate the aides. So it orients the aides in background on sepsis. The aides often use these in discussion with patients and families. It's often attached to the refrigerator, so people can also follow this. And again, as you see, these criteria are important not just for sepsis, but they're important in and of themselves for important criteria to report back to the clinician at the home care agency if there is an issue that arises with any of these in the patient. This next slide shows the protocol. And the protocol more or less embeds the key criteria of the tool in a series of instructions and guidance for how the tool is to be completed at each phase of this process. So the protocol is really to help ensure that every home care agency, every clinician is completing the tool the same way for every patient throughout. One of the things that we have found in the training sessions that we've conducted is there's a tremendous amount of consistency and inter-rater reliability in the completion of this tool. We conducted sessions from Buffalo to Long Island and in between, and part of those were exercises in clinicians completing the tool. To a T, the tool was always completed with the same kind of outcome and the same consistency and recommendations for follow-up, which is really a good validation of the tool, and its capacity to be functional and effective in this milieu. So the protocol is very, very critical, and that again was all part of what is important in the user agreement and in the ultimately in the adoption and use of the tool. So some key points about the tool. Screening is to be completed at the start of care, resumption of care, and at every clinical visit. So if you're not using the tool, it sounds like, wow, this is a lot. We can't really afford to have anything additional added. What providers found in their experience using the tool is it really fits in seamlessly with the assessments that you're already doing on the patient. You're already looking for these criteria, but it's a way of organizing the assessment such that you're on the look for the criteria as they correlate for potential of finding that this patient might be septic, have severe sepsis, or beyond. So that's really very, very key, that it's done on every visit. The interventions, as I mentioned, are recommended intervention. They're not a substitute for treatment. They're not a substitute for your judgment. If you see a patient that presents in such a way that you feel that there needs to be intervention and it's not indicated on the tool, then you go with your judgment in those cases. Also, if clinicians choose to order tests or interventions that are not listed on the tool, they all need to be documented, and referred to the nursing note and documented on the intervention that was ordered. And again, emphasizing that the patient and public education is a significant part of this process. Now we'd like to go through some case studies on this. So
sure. So these are the case studies that we feel really cover all of the different scenarios that you might encounter when using the tool. So a 49-year-old female admitted for nursing care for a diabetic foot infection. She is receiving IV antibiotics through a PICC line. She is seen 3 times a week for dressing changes to her foot, wound, and assessment of her wound, and assessment and maintenance of her PICC line. The patient's wound has been progressively healing with improvement in appearance and decrease in the size of the wound. Her vital signs are temperature 98.4, pulse of 72, respirations of 18, and blood pressure of 116/70. The patient is alert and oriented ×3, breathing is easy, denies any pain, and her skin is warm, pink, and dry. She denies any complaints with bowel or bladder function. So if you use the sepsis screening tool, it indicates that for question 1, yes, the patient has an active infection, a wound infection, and the patient also has a source site for a potential infection through the PICC line. Question number 2, the patient does not have any systemic criteria. Question number 3, no, the patient does not have any signs and symptoms of a new onset organ dysfunction. So the follow-up for this patient would be, number 1 was yes, but 2 and 3 are no. So the patient was educated on the signs and symptoms of sepsis and provided the early signs and symptoms of sepsis patient education tool. Scenario number 2, a 91-year-old female admitted with COPD, a history of frequent pneumonia with possible aspiration and confusion related to dementia. The patient has a history of urinary incontinence. The patient has a supportive daughter in the home who is her primary caregiver. Upon assessment, the nurse determines that the patient has a temperature of 96.6, a pulse of 110, respirations of 26, and a blood pressure of 101/60. The patient is holding her stomach and stating that her stomach hurts. The daughter reports that her mother has also been confused over the last day and that her urine seems to have a strong odor to it when she is caring for her. So the sepsis screen indicates that for question 1, yes, the patient has a potential source of infection with incontinence and a history of potential aspiration pneumonia. Question number 2, yes, the patient does have 2 systemic criteria. And question number 3, yes, the patient has signs and symptoms of a new onset organ dysfunction. So the follow-up for this patient would be that questions 1, 2, and 3 are all yes. So the patient meets criteria for severe sepsis. The patient was educated on the signs and symptoms of sepsis and provided the early signs and symptoms of sepsis patient education tool. The intervention is that the patient requires immediate treatment. So the doctor is notified and the patient is transported to the emergency department and the report is called to the receiving emergency department. Scenario number 3 is a 65-year-old male admitted for diabetic teaching due to being new, admitted for diabetic teaching due to being new on insulin. He has a history of pneumonia and coronary heart disease. The patient does have a supportive wife at home who is supportive. Upon assessment, the nurse finds a reddened area to the lower right leg. The patient has a temperature of 99.6, a pulse of 100, respiration of 22, and an SpO2 of 98%, a blood pressure of 120/60. The patient has no complaints of pain, GI or GU issues. So the screen indicates that yes, the patient does have a potential source site of infection with a reddened area to his lower leg. Yes, the patient does have 2 systemic criteria. And no, the patient has no signs and symptoms of a new onset organ dysfunction. So the follow-up for this patient would be, since 1 and 2 are yes and 3 is no, the patient meets criteria for sepsis. So also this patient is educated on the signs and symptoms of sepsis and given the patient education zone tool. The patient meets sepsis criteria, so the doctor is notified, antibiotics are initiated, and the next skilled nursing visit will be completed within 24 hours. Scenario number 4, an 88-year-old female admitted with new onset CHF. The patient has a baseline mentation of being alert and oriented. The nurse has been completing CHF teaching with the patient over the last few visits, and the patient has been completing all of the follow-up the nurse has instructed her to do, such as monitoring her daily weights. At today's visit, the nurse's assessment is as follows. Temperature is 98.6, pulse is 76, respirations are 18, SpO2 is 98%, and the blood pressure is 134/78. Bilateral lung sounds are clear, does not appear to be any type of discomfort. When the nurse asks the patient if she has any pain, she appears to be confused and is unable to answer the question. As the nurse continues with her assessment, the nurse notes that the patient has a new onset of confusion with no facial droop or unilateral weakness. So this screening indicates no, the patient does not have any noted infection or potential source site of infection. And no, the patient has no systemic criteria. But yes, the patient has signs and symptoms of a new onset organ dysfunction. So the follow-up for this patient would be questions 1 and 2 are no, and 3 is yes. So the patient meets the criteria for doctor notification. The patient is also educated on the signs and symptoms of sepsis and provided the early signs and symptoms and sepsis patient education tool. The intervention for this patient would be that the doctor was notified and requested to see the patient in his office. Transportation arrangements are made with a family member.
Thank you, Eve. And those cases we hope really help bring to life the application of the tool in actual scenarios, and we'll emphasize that those are actual cases where the tool was applied, and those cases were supplied for this webinar by Amy Bowerman. So now just talk about guidance for agency adoption and use. So our guidance to all agencies is that the The sepsis tool and the protocol are adopted within the formal policies and procedures of agencies, including procedures to ensure the completion of the sepsis screen on every RN assessment and clinical visit, unless it's contraindicated by the MD, and that it be incorporated in the agency's Quality Assurance and Improvement Committee review process. That the tool be integrated into the agency's electronic health records. I would pause here and say that has probably been the most substantial challenge across the state, is the integration into the EHRs. We have agencies that are using the tool that are not on electronic records. They use the tool in paper form, and they track they track the progress of their cases. The forms go into their records. Other agencies that have electronic records have successfully incorporated them into those records. Home-based is one of the software companies that from the outset established a successful build. So if you use that as your EHR company, they're already on board and they have the build. And we know that there are several other companies in the state that have been actively working to create the bridge to integrate the tool. There's a separate webinar that we conducted with EHR companies that would be available to you to offer you some further guidance in that regard, and agencies that have successfully integrated pretty much volunteer themselves on an ongoing basis to any agency that wants to consult with them. Also, another important element in implementation is the training of all of your clinicians on sepsis and the use of the tools, including all the various tools that we showed you today, and that would be including a connection to the webinar series, the case scenarios, etc. Also very important would be to utilize those resources that we showed you, Sepsis Alliance and the Stoughton Foundation, for additional and ongoing training. Sepsis is something that has developments ongoing in terms of both the science of it and the intervention, so it really is important to keep up on all of these developments in the process. We've also created, Eve was the leader in this, creating a timeline for training and implementation that you'll see on the next slide. There is not only a timeline, but a whole set of training and guidance tools that have been assembled onto a DVD that Eve will walk you through. The other is outreach and collaborative training with your partners. Physicians, hospitals, EMS, managed care organizations. It's very important that as you adopt this tool, that your partners know that you have the tool, and that the tool, again, is something that in a standardized way communicates with the protocols in EMS and in hospitals. Again, very, very important that kind of outreach be part of what you do in the adoption of the tool. So, Eve?
Sure. So we created this timeline to keep everybody, kind of standardize the whole process, and to keep everybody on track with the training, and make sure that you meet all the critical elements for implementing the tool, and also make it easier for you to see what your next steps are and what preparations you need to make for that. I'm not going to go over every single element of the timeline. Essentially, it will start with your signing and returning to HCA your user's agreement, reviewing the contents of the DVD, and then you're going to start your staff training, and then you're going to begin using the tool. And then within 2 months of the training, the goal is to have all of your staff trained. After that, there will be periodic office hour calls that we will definitely notify you of, and of any other ongoing activities.
And I just want to also be sure everyone is aware. So the training material, all of our background is available to all of you in conjunction with your going ahead with this initiative.
So we created this DVD, this toolkit, to help keep all the training materials in one place. You can print them out as many times as you want, and we just feel like it worked very well with the IPRO's Train the Trainer program for community-based sepsis awareness, and we feel it'll really help simplify the whole training process.
Can they request it from you?
Yes, and I will get to that. You can request that that DVD actually from me. And is our contact information at the end there? Okay.
I sent your email.
Okay, great. So Felicia just sent my email information out. So what is contained on the DVD? It essentially is divided into 3 different folders. The first one addresses basic sepsis training, and this will give you a couple of different PowerPoint presentations, as well as all of the training tools, the zone tool, the brochure, the stop and watch, everything that we use for our sepsis training. The second folder is specific training on the HCA adult sepsis screening tool, which Al has just been going over in detail. And then the third folder are links to educational and training resources. And then this is a list of our contacts for Al, myself, Sarah Butterfield from IPRO, Amy, and also Thomas Heyman from Sepsis Alliance, and Orla Staunton from the Rory Staunton Foundation.
So collaboration is really a key in making this work, collaborating with your individual clinical partners. And so some of the lessons and recommendations and experiences that we've encountered across the state, and in our actually even in the course of the training that we've done, are really some important findings in this, and we'll go through some of those. So again, collaboration across continuum partners is very critical to the effectiveness. The standardization of the screening and intervention is very significant to the collaborative process, especially for hospitals, EMS, and physician partners to know that you're utilizing a standardized tool and criteria, that the tool is aligned with criteria for sepsis use in hospitals and EMS, and that I think that the trainings that we've done, as I've mentioned, have revealed some important gaps and areas and opportunity areas in the process. So one relates to report to ER in consultation with physicians. So it's very, very critical in reporting to ER that the nurse who's reporting indicate that you completed a sepsis screen, that this is a patient where sepsis is suspected, and an indication of the reasons why. And the same thing in consultation with the MD. We believe that will make a significant difference in terms of whether or not, when that patient shows up at the ER, they are treated with the urgency that's required. There was a case example that Eve and I were both present for, in terms of the description, where a patient went to the ER, was sort of awaiting further evaluation, and by the time the patient was processed through ER and ended up being placed in an actual bed, the patient ended up in critical care, in respiratory failure, and on a ventilator. So that's how fast, even though it was over a period of hours, but that's how fast that patient progressed and crashed. So the idea of the report is very important, and it's an area where there would be a gap if it's not reported effectively to ER or to the physician. Information exchange upon ER referral is also very important. So if the patient's being transported by EMS, it's very important that EMS really have the workup on the patient. What are the findings that led to the referral to EMS and now the transport to hospitals? And again, very specifically, so that information can be acted on quickly in the ER. On post-sepsis treatment, so on discharge from hospital to home health, many agencies have reported, actually I think every agency has reported the fact that they often receive cases that have been referred to them for post-pneumonia treatment, UTI, other conditions where sepsis is never indicated. And we know that these individuals are going to be at higher risk for readmission and more fragile. So one of the areas that we are working on with the Hospital Association and the Department of Health is how do we ensure that on discharge that information is appropriately presented. But in working with our own clinical partners when receiving cases, that's an important area to try to cover. Another area is really the clinical pathway and interdisciplinary care planning for post-sepsis discharges. we know that there are multiple conditions that affect an individual on an ongoing basis if they've been treated for sepsis, or that could be in effect for those individuals. And so a very important area and a gap in the system is to try to ensure that there is appropriate coverage for that interdisciplinary care. And we'll talk about that further as we go along. Mutual education and awareness of the use of the tools and criteria across sectors. So what's really very important in collaboration is for EMS and physicians and others to know that this tool is being used, and for you to know what tools and criteria they're using. And this is something that at our level, working with our association partners, we're working to try to further that. That's something the State Office for Aging is also working to try to support, but that's really an important part of the process. Data sharing is also very important, and again, that's something that will come about by your use of the tool and your sharing of the data through the portal, and for us to be able to work with partners in having better insights in terms of how all partners can work together toward this problem. A specific scenario from the Mohawk Valley Health System that was shared. Their hospital staff was invited and attended the training in the home care sepsis tool. In turn, the home care agency, so this would be the VNA of Utica, was also invited to participate on the hospital sepsis committee. So there's very good active and ongoing discussion and coordination about sepsis patients and best practices that can be implemented in terms of addressing the needs and concerns of those patients. And also the hospital and the home care management teams have collaborated to use the same educational materials, such as the Zone tool, in educating clinicians and the public generally about sepsis. Electronic health record integration. So I think we pretty much covered this in our other comments on the other slides, but whenever possible, the integration of the tool with the EHRs is really very vital. You know, it makes the process much more seamless and automatic, enables the information to be automatically integrated with other key information, and provides an additional data profile which will benefit your agencies as well as at the statewide level and in terms of population health indicators. And I mentioned that if you go back to in the earlier slide, there was a link to all of the webinars that we've put together, and one of those webinars specifically addresses EHR. But as you know, this is again a progressive process, so that if you're working to integrate, I think one of the best things to do is to either reach back through HCA or through IPRO, and we can connect. We can either help you or connect you with an agency that is utilized or is utilizing an EHR company and has integrated the tool, and they can help you with guidance on how you can proceed. Before we go through next steps, want to stop and see if there are questions. You know, one question in the queue already is, when will the pediatric tool be ready for this? So we have been having conversations with national experts to have a pediatric version of this tool, because the criteria and the cutoff points are different for children and actually in different age groups in the pediatric population than they are for adults. And this has been a bit of a moving target, because there's still a lot that is evolving at the national level, and there's a bit that's, as I said, still progressing and really not as certain. We know that the Department of Health and its sepsis advisory group is looking carefully and been assimilating data on the pediatric population. So our next move really is to work with the department to see if we can capture a reliable set of criteria that we can issue in the next iteration of the tool. We're a little bit anxious to try to get this moving, and I know that there are agencies working with pediatric populations either exclusively or substantially looking for the pediatric version, and we're really onto that as quickly as we can put that into place. A little bit frustrated with the length of time that it's taken, but it's really more reflective of the evolution of the state of the art in that field itself. There's another question on is there or will there be additional on-site trainings for agencies to attend? I would say yes, we will be holding more on-site training, but we don't have them specifically planned to date. We conducted them pretty regularly throughout the past year, and there are additional venues even since that time where we've conducted training. Even I were just in the North Country 2 weeks ago conducting a training there. So just be on the lookout for announcements to that effect. We certainly would look forward to opportunities to further introduce, but in the meantime, the webinar series is really a critical place to go. Are there additional questions? I think I see another comment in the queue. One of our frequent problems is that we send our patients to ER for follow-up on high-risk patients and inform hospitals that this is a home care patient and request correspondence for patient discharge, so we prepare for anticipation of the changes. However, we often find our patients were discharged home without notification and are often uncertain of the diagnosis made in inpatient setting. These patients often have family who are not well educated on the patient's, looks like the patient's diagnosis. So I think that, thank you for that. I mean, that's very consistent with the point I raised earlier in the area of collaboration, where this has been identified as I would consider this a very serious gap in the system, where patients are being discharged home, either with or without home care, and without effective information on the fact that they may have been treated for sepsis or a high-risk condition for sepsis upon discharge. If they're, again, let's say they're a recurrent UTI or recurrent pneumonia patient. One of the initiatives that we are going to be working on in follow-up with our sister sectors is sort of a best practice document that would look at providing guidance to every sector, so to hospitals, home care, physicians, EMS, behavioral health, across the sectors, on what's important in cross-continuum work for effective sepsis care, and this is one of those areas that we would address as part of that process. I think in the near term, I think most important is to be communicating with hospitals when you're receiving discharges that seem to be incomplete. Also, you can let us know what your experiences are, and we can sort of work to bring that up the chain. This is also just an area generically in terms of these care transitions that we are also looking forward to working on with the hospital community. As we go forward, to just look for important initiatives that can simply improve the experience of the patient and the transition of the patient. A more informed discharge process is obviously very, very key to that effort. And it was something that actually was in a discussion that I had last week with senior leaders at the State Hospital Association. And we've been talking about different approaches to that, but specifically in sepsis, this collaboration approach is something that we would be looking to accomplish.
No, absolutely. We get that comment at every single training session, I think.
Okay, so another question. Have agencies incorporated the tools with a home health aide staff? Yes. So agencies have very effectively utilized the patient zone tool in use with the home health aide staff. I mentioned earlier that the aides have actually responded incredibly positively with this, not only with greater awareness of sepsis criteria and their work with the patients and families, but also have utilized that increased awareness to report back to the agencies anytime they see these risk criteria, because the risk, even if the risk criteria isn't pointing to sepsis and maybe pointing to some other problem requiring intervention and therefore avoidance of an emergency, or some other serious deterioration in the patient. So yes, it's been very successful. I would also point out that one of our agencies, and perhaps more than one, but one agency in particular has developed and actually presented at our quality conference and our senior managers conference on Financial Managers Conference on a value-based payment initiative that is a training protocol for the aides in sepsis identification. That's something that we're going to be looking to actually post to our website so that you have available, and we'll be inviting that agency further to provide presentations to the membership. But yes, that's been a very effective part of what's occurred. Do you have PT, OT, ST complete the tool if they are the only discipline involved, or just RNs? Yes, all clinicians are completing the tool and report their if you're integrated, the findings go right into the EHR. But otherwise, findings associated with this get reported back to the RN who's on the case, and then there's appropriate follow-up with the patient. Now, in the case of the LPN, because scope of practice in New York does not allow an LPN to assess, an LPN can still complete the tool, but the report of the findings and the assessment has to be made by the RN, reported back to the RN. Are there additional questions in the queue? Okay, seeing none at this time, and please feel free to add, let me just take a minute or two just to talk about next steps in the process, and then we'll wind up. We're right at noon right now, but we'll just take a couple of minutes. So in our next steps are continuing this in-depth training on the tool. Again, this is not something that we're just rolling out and then and saying, here it is, do well with it and let us know how you do. This is something that we are continuing to work on together, and will continue to be a partner in this process, really trying to progress and further build on the work that we're doing. We also are continuing to promote cross-sector coordination, and as I mentioned before, in our work with the hospitals, the medical society, EMS, other partners. And our goal is really to foster a coordinated continuum response to sepsis. We will also be working with partners on joint education and collaboration. I just did a program with the EMS Association, and we presented to their board on this joint initiative, and EMS and HCA are also looking to do a statewide presentation for EMS and for home care. Also work with the Health Plan Association and other communities on joint education in this area. We held in October the first of its kind in the country, an all-sector statewide summit. And even the team at IPRO, at Haney's, at HCA, Sepsis Alliance, Staunton Foundation, the Health Department, Office for Aging, we all collaborated in this, as well as the State Nursing Home Associations, the Medical Society, and others. And we basically had a summit that comprised close to 200 facilities and providers across the state who all came together to talk about what each sector is doing and how we could better work together. We have some outstanding recommendations from that summit. There is a plan for a part 2, which the State Health Department would like to lead in terms of data presentation, and also other recommendations from this that will lead to some program areas. I'm going to move to just one of those here, which is the development of legislation. So the Senate last year, the State Senate unanimously passed legislation that would provide support for the initiative that Eve and I have been describing today, and at all levels, at the training level, EHR integration, collaboratives with hospitals and home care, and community outreach and education. Those are all part of that legislation. So that passed the Senate last year. The bill is introduced in the Assembly by Assemblyman McDonald. He's a pharmacist. He actually came to our sepsis summit, and we have a meeting with him coming up in the next 2 weeks to hopefully advance this legislation or something very similar to it. We are also working with the governor's office and the health department. So those are some very important next steps. Some other ones include application of the tool to other sectors and provider types, continued assistance to other states. One state in particular, the Illinois Association, today at their board meeting is discussing the statewide adoption of their tool in Illinois. Massachusetts has adopted the tool. We're working with the Washington Association, the Ohio Association, all the New England associations, et cetera, to work toward the adoption of this tool. The other thing that we talked about is the survivors. So a major part of the work that we're doing, which is also addressed in the legislation, is promoting the development of a plan of care post-discharge that addresses all of the different interdisciplinary needs of an individual, physiological, psychological, vocational, basically family and quality of life issues. There are so many issues associated with survivors. I think it's estimated that there's 38 amputations a day due to sepsis. So if you imagine just on that alone the extent of the impact. So we're working on trying to model and have approval to implement complete interdisciplinary programs for patients surviving sepsis. One other major change is the governor signed last October, actually, something called Rory's Law. So building on Rory's regulations, this law mandates sepsis education in schools throughout the state, and that's already begun, and also includes sepsis education as part of the 4-year infection control and prevention requirement that all clinicians are obligated under for renewal of their license. So we will also work with them and the legislature and the education department on that. This is a slide that gives you links to all the resources that we talked about. The Centers for Disease Control have also posted all of the webinars that Eve and I and our team, Sarah Butterfield, Amy, Tom, and Orlith, and Kieran Stoughton and our team have put together. And that's a great endorsement really by CDC in the work that we're doing. So that's another place that you can access. But on any of these links, you can access very, very key information. And that's all of our contact information if you have follow-up questions for us. I don't see other questions in the queue. We're a couple minutes past our time, but let me pause and see if there's any other comments or questions on any of you in the queue, or Eve. And I just want to sum up in this way. So first of all, I want to thank everybody that participated in this webinar. So I think very, very key to the goal of having an effective response in the home care community is really having everybody on board. And we really appreciate your commitment of time and interest and consideration to this effort. As I say, this was not mandated on home care. It may well be at some point, but we are way ahead of the curve, not only in New York, but nationally in intervening in this #1 problem. I don't know if you caught this, but over Thanksgiving, one of the members of the state Senate, a 47-year-old state senator, died of septic shock. 2 children at home, died very, very rapidly, and I think ironically, a statement attributed to one of the physicians was, well, this is very, very rare. Well, no, it's not very rare when every 2 minutes somebody dies of this condition in this country, and when we know it's the top hospital cost and killer and top source of readmission. It's not that rare when we know that. So that really sort of cues up the irony of what we're trying to intervene in. The second thing is, for those who are interested in moving forward, the main thing for you to do is, in one of the slides in the middle of this, there's a website to go to inquire on the user agreement. So it's really sepsis tool at HCA.org is the website. Send an email to that website indicating that you're interested in pursuing this, or if you email myself or Eve or Sarah or Amy, the folks that are on this list in the back, you can email us and we can also guide you through the process. We'd be delighted to work with you, and we'll work with you soup to nuts to assist you in putting this all in place. And with that request would also come and be granted all of the tools, the DVD, all of the training, all the supports that we can provide to you. So with that, again, I want to thank everyone for being part of this process and part of what really is a pioneering effort in New York, in public health, and in the country for intervening on this very, very serious problem. Together, if we work together, there's no question that we can save lives, save health, and save an abundance of costs within our healthcare system. Thank you, one and all. You were spectacular. No.
Not like you.
No.